Hello and welcome to the Wiley podcast series, Knowledge to Impact, where medical education meets real-world change. This series aims to deliver latest content updates from our Knowledge Hub program. This is our third episode on cancer cachexia, a progressive muscle-wasting syndrome that significantly diminishes the quality of life for many patients with cancer. The Cancer Cachexia Knowledge Hub was developed in partnership with the American Cancer Society and has been supported by an educational grant from Pfizer. Today we are joined by Associate Professor Richard Dunne, who discusses the case study of a patient with cancer cachexia, offering insights into the medical management of involuntary weight loss. The case study also explores challenges and strategies in ensuring mental health support, physical activity, and nutritional care for patients with cancer cachexia. This discussion was originally broadcast as a webinar. A link to the original accredited activity, including information on how to claim credit, faculty disclosures, and the slide presentation can be found in the show notes. We're glad to have you with us, and we hope you enjoy this episode.
Hello, my name is Richard Dunne. I'm a medical oncologist based in the United States at the University of Rochester Medical Center in Rochester, New York. And I'm pleased to review a case study in cancer cachexia. This is an actual patient that I saw early on in my training that left an indelible mark on how I view patients with cancer who experience weight loss and muscle wasting. Let's begin. So Larry is a very active 67-year-old male when I first met him, who presented to my office with newly diagnosed pancreatic cancer. He initially sought medical attention from his primary care physician due to symptoms of epigastric and back pain that were not severe, but were enough for him to take notice. In addition to this, he had an increase in frequency of stools that were more loose than compared to baseline. In terms of Larry's family history, he had a mother who was diagnosed with pancreatic cancer in her 70s, a father with coronary artery disease, and two siblings, none of whom had cancer. In terms of his social history, his occupation was he was an engineer, he was married, he had two adult children, both were healthy. He was a former smoker, but quit about 2 decades ago. In terms of alcohol consumption, it was rare, maybe once or twice a month. So an evaluation of his abdominal and back pain, his primary care doctor ordered a CAT scan of the abdomen and pelvis that showed a 4.5 centimeter hypoechoic mass in the body of the pancreas. And unfortunately, multiple metastatic lesions were seen in the liver and the lungs. Blood work was not very remarkable other than a mildly elevated ALK-Phos and AST-ALT, but a CA19-9 was elevated to 4,500. The patient underwent an endoscopic ultrasound, which again showed a hypoechoic lesion in the pancreas body, and a fine needle aspiration was performed, which found adenocarcinoma, confirming the diagnosis of pancreatic cancer. So further on the case, in terms of Larry's history of his physical activity and lifestyle, very active leading up to his diagnosis and his initial visit with me. He had a history of being overweight since his late 40s, and he took up long distance running and was very proud to discuss that he started to run marathons in his 60s. 5 years ago, along with picking up running, he embarked on a significant weight loss journey by taking up running, as I said, losing over 100 pounds during this period. Recently, he had experienced further weight loss, which it was questionable whether this was intentional, and he shed an additional 25 pounds in the past 3 months. His appetite was normal. We talked about how he had an increase in frequency of stools, about 4 to 5 bowel movements a day. The bowel movements would typically occur shortly after meals, associated with abdominal cramping, and stools have a greasy consistency, indicating possible malabsorption. Medical history was not too remarkable, other than having a history of diabetes, which we know is a risk factor for pancreatic cancer. On exam at the initial visit, Larry's a thin man, uh, normotensive, no acute distress. He had mild tenderness to palpation in the epigastric region, but really no other abnormalities on physical exam. So going back to Larry's weight, which was kind of tricky given his long distance running. In the past 3 months, he lost 13.5% of his body weight, which, although he had previous goals of weight loss some years back, it did appear that the most recent was more unintentional. He was starting to get thinner, kind of past his original weight loss goals. And this weight loss of 25 pounds, he had been closer to 180, 185, was greater than 5%, which has been for over the last decade has been one of the diagnostic criteria that's used to indicate cancer cachexia, greater than 5% unintentional weight loss in the past 6 months. And so we find that when weight loss becomes severe, that it is harder to stop and potentially reverse. And so early intervention is key. Really honing in on this weight loss and understanding that it's unintentional to intervene is really important here. So my recommendations at the initial visit follow a lot of what we see in the ASCO guidelines for cancer cachexia. We referred him to a dietitian, and with signs of pancreatic insufficiency, we started him on pancreatic enzyme replacement therapy. We advised him to continue the active lifestyle, but provided caution of long-distance running, given metabolic changes he was experiencing with the diagnosis of pancreatic cancer. He underwent palliative chemotherapy with FOLFIRINOX, and he received, when I saw him next, he had received 3 cycles of FOLFIRINOX, and it looked like his cancer was responding. The CA19-9 had cut over 50%. However, despite this possible improvement in the cancer, Larry was clinically declining with increasing fatigue and depression that was impacting his quality of life. He was unable to run, an activity he previously enjoyed. But despite less activity, his weight had further decreased and he lost another 15 pounds. His loose stools had resolved with the initiation of pancreatic enzymes, potentially showing an improvement in his absorption. His new symptoms included early satiety, food aversion, and nausea, particularly severe during the first of his 2-week treatment cycle. And nausea, managing his nausea, he'd been using ondansetron and prochlorperazine, and it was deemed, his nausea management was deemed insufficient. So with his pancreatic insufficiency now well managed, but the initiation of a platinum chemotherapy, which has further led to progression of his cachexia, he was now experiencing more symptoms related to his treatment, namely nausea and poor appetite. This is commonly seen with these aggressive chemo regimens. He also was showing signs of inactivity and depressed mood, which are also common in patients with cancer cachexia. And so at that time, I think one of the important things is that the management of the symptoms of cachexia and the syndrome of cachexia are ongoing. It's not something that's limited to the initial visit. It's something that is ongoing throughout the patient's journey for treatment of cancer. And so at that time, in the follow-up visit, what we recommended was initiating low-dose olanzapine. At this time, it wasn't something that was as commonly used as it is now to treat nausea, but has also made its way into the cachexia guidelines as it has been shown to increase, not only improve nausea, but also increase weight in a randomized study, and is now in the ASCO Cachexia guidelines. We referred for mental health support. We referred to social work and discussed potentially starting an SSRI. Given his physical activity had decreased, we set up referral to physical therapy to help reintroduce safe and effective low to moderate intensity physical activity. And we arranged ongoing follow-up with our dietitian colleagues for calorie count, and he assess his needs for dietary and protein supplementation to help support Larry's nutritional needs. So we'll conclude there. I hope this case was helpful at showing the challenges that we face in patients who have cancer, who are also receiving chemotherapy, and the need for ongoing management and follow-up of symptoms of weight loss, muscle wasting, fatigue, and worsened physical function, which is the syndrome of cancer cachexia. Thank you.
Thank you for joining. If you enjoyed today's episode, don't forget to share it with your colleagues and subscribe to our channel. If you'd like to learn more about cancer cachexia, you can access additional educational resources, including CME credit opportunities, on the Wiley Knowledge Hub. For more medical education from Wiley, visit Wiley Focus. All links are in the show notes.